Hello, everyone. It's good to have you back. So I did enjoy my coffee break. I actually had a cup of tea, Earl Grey tea. Now it's my great pleasure to introduce the following keynote lecture. And you have noticed how excellent every single keynote lecture has been in this meeting. It's a particular pleasure because I'm introducing a friend, Mauricio Delgado, who's like me, a pediatric neurologist, neurophysiologist, neurorehabilitation doctor in Texas. And he's a past president of our sister academy, the American Academy of Cerebral Palsy and Developmental Medicine. Mauricio has recorded this, and so he's not really live, but we can feel his presence. The theme is very important to many of us, and as an excellent clinician, a very subtle clinician, it's good to hear from Mauricio how we're going to distinguish between cerebral palsy and HSP, that is hereditary spastic paraplegia. Mauricio, we're listening to you. Thank you for sending your video. If you have questions, you can ask them, but that will be delayed. You can send them by email to Mauricio. His email is in the chat.
Hello, everybody, and thank you so much for inviting me to participate in your Congress. I'm very sorry we cannot be together in person, especially when the meeting was going to be in beautiful Poznan, but I hope in the future we can meet again. In the meantime, I want to congratulate the organizers of the meeting for going through the extra effort to be sure this meeting took place. As you know, today we are celebrating Thanksgiving in the United States, and so this is a very important family celebration. So this is not going to allow me to be present in the live Q&A. However, I will put my email at the end of my presentation, so you can send me an email with your questions or comments about my talk if you wish, and I'll be more than happy to respond to you that way. So today I will be discussing a topic that has become more and more relevant as we have better access to genetic diagnostic tools that can help us uncover disorders like hereditary spastic paraparesis, which can really mimic CP. But before I start my presentation, I'd like to declare my conflicts of interest. And let me start presenting a clinical case that can help illustrate the importance of being on alert about the possibility of a misdiagnosis in patients who present to us with a clinical picture consistent with cerebral palsy. So this was a 3-year-old boy who was referred to me with a diagnosis of cerebral palsy, presenting as a spastic diparesis. He was referred to me to do a spasticity management of his lower limbs with botulinum toxin. His gait difficulties were noticed since he started walking at the age of 12 months. And this impairment had been pretty stable since the beginning, without presenting any signs of regression. Actually, his parents reported to me that since he started having physical therapy and was able to use a K-walker, they thought he had become more independent for his ambulation. The child had had a diagnostic workup somewhere else that included a brain MRI that showed a Dandy Walker variant, and the referring physician thought this was the reason for his neurological disorder. His past medical history was unremarkable, and besides his gross motor delay, his other developmental milestones had been achieved at a normal age. Besides the brain MRI, he had also had a chromosomal microarray that was reported to be normal. His family history was unremarkable. He was the only child. On exam, he was a very bright and attentive child who was able to follow commands appropriately. With the exception of the spastic paraparesis, his neurological exam was normal. He was able to ambulate with a gait reverse walker, showing a gait with bilateral equinus and excessive hip and knee flexion during the whole gait cycle, as you can appreciate on the video. And he tended to use his upper limbs to support himself due to excessive weakness in his lower limbs. He could only take 1 to 2 steps independently before he would fall. His deep tendon reflexes were normal in the upper limbs, and they were increased at the knees and had bilateral ankle clonus and Babinski sign. His MRI was reviewed and considered non-contributory to his neurological disorder. His foreventricle had a normal size and shape. His cerebellar vermis was normal, and he only had an asymmetric megacisterna magna, which was observed on the left side of the brain. So we proceeded to do an MRI of the spine, which was normal, and then we ordered an HSP genetic panel that revealed a heterozygous frame shift mutation in the spastin gene consistent with SPG4 hereditary spastic paraparesis. The mutation was inherited from his mother, who at that time was asymptomatic. So here we have a case that clearly illustrates how easy it is to confuse childhood onset HSP with cerebral palsy, particularly spastic diparesis. These patients look, feel, smell like cerebral palsy, but they do not have CP. So what constitutes a CP mimic? So for the purpose of this presentation, we will consider a CP mimic a disorder that presents clinically as CP in the absence of risk factors or imaging findings consistent with cerebral palsy. That is a spastic motor disorder with onset before age 2 years with evidence of neurodevelopmental regression and normal or non-specific findings in the brain and spine MRI. But before I continue, let me present another case that will help us keep an open mind about other CP mimics besides HSP, even if the history is supportive of cerebral palsy. This was a 6-year-old girl referred to me for tall walking since ambulation started at the age of 14 months. She also complained of some pain in her lower limbs that did not require medication on a regular basis. There were no activity limitations other than she would occasionally trip and fall. She attended regular classes at her local school and did not have any developmental delays. There were no bowel or bladder problems either. In terms of pregnancy and birth history, Mom had hypertension during the pregnancy and ended up with an emergency C-section at 33 weeks of gestation due to some fetal distress. Her birth weight was 3 pounds. She was mechanically ventilated and stayed in the NICU for 6 weeks. No problems with her development. She spoke first words at 12 months, walked at 14 months, as we said, and she was toilet trained before age 3. Nothing significant in the past or family history. On examination, she was a vibrant and sociable child with normal speech and without cognitive or behavioral problems. She had a spasticity and fixed flexion contractures at the knees and the ankles, and had bilateral ankle clonus and Babinski sign. His MRI was reviewed and considered non-contributory to his neurological disorder. His foreventricle had a normal size and shape. His cerebellar vermis was normal, and he only had an asymmetric megacisterna magna, which was observed on the left side of the brain. So we proceeded to do an MRI of the spine, which was normal, and then we ordered an HSP genetic panel that revealed a heterozygous frame shift mutation in the spastin gene consistent with SPG4 hereditary spastic paraparesis. The mutation was inherited from his mother, who at that time was asymptomatic.
So here we have a case that clearly illustrates how easy it is to confuse childhood onset HSP with cerebral palsy, particularly spastic diaparesis. These patients look, feel, smell like cerebral palsy, but they do not have CP. So what constitutes a CP mimic? So for the purpose of this presentation, we will consider a CP mimic a disorder that presents clinically as CP in the absence of risk factors or imaging findings consistent with cerebral palsy. That is a spastic motor disorder with onset before age 2 years with evidence of neurodevelopmental regression and normal or non-specific findings in the brain and spine MRI. But before I continue, let me present another case that will help us keep an open mind about other CP mimics besides HSP, even if the history is supportive of cerebral palsy. This is a great teaching case, by the way. This was a 6-year-old girl referred to me for tall walking since ambulation started at the age of 14 months. She also complained of some pain in her lower limbs that did not require medication on a regular basis. There were no activity limitations other than she would occasionally trip and fall. She attended regular classes at her local school and did not have any developmental delays. There were no bowel or bladder problems either. In terms of pregnancy and birth history, Mom had hypertension during the pregnancy and ended up with an emergency C-section at 33 weeks of gestation due to some fetal distress. Her birth weight was 3 pounds. She was mechanically ventilated and stayed in the NICU for 6 weeks. No problems with her development. She spoke first words at 12 months, walked at 14 months, as we said, and she was toilet trained before age 3. Nothing significant in the past or family history. On examination, she was a vibrant and sociable child with normal speech and without cognitive or behavioral problems. She had a spasticity and fixed flexion contractures at the knees and the ankles. Hyperreflexia was noted in the lower limbs with 3 beats of clonus, and she had a bilateral Babinski. Deep tendon reflexes were normal in the upper limbs. So what do you think? CP, spastic die, stable, probably secondary to PVL. She was a premature baby, and she was in the NICU for 6 weeks. Well, that's what a lot of people thought about her, and that's why nobody bothered to look for any brain imaging, which we could not find either. And that is why we ordered a brain MRI. And this is what we found. This is a flare to T2 axial cut of her brain. And you can see it's totally normal. No PVL or any other abnormality. So what do you do next? Yes, a spine MRI, which we did. And to our surprise, we found that she had an extradural spinal tumor involving the cauda equina, which ended up being a ganglioneuroblastoma. It took all these years to come up with the correct diagnosis because everybody thought and assumed that she had cerebral palsy. So we need to remember that the definition of CP is of a clinical syndrome and does not imply an etiology other than the syndrome is caused by a non-progressive disturbance of the developing brain. So it is our responsibility to determine the etiology that is clear and well-defined as early as possible for a number of reasons. First, some of these CP mimics may be treatable and an early treatment may prevent further neurological deficit. Second, the family can be provided with more accurate information regarding their prognosis. And finally, genetic counseling may be offered, including where appropriate prenatal testing. So how often is CP misdiagnosed? Well, there is not sufficient data to provide an accurate answer to this question. Studies using the South Australian CP registry reported that as many as 5.2% of children that were originally diagnosed as CP were later identified as having a non-CP diagnosis. And in the majority of these cases, they had the diagnosis change at age 5 or later. A recently published study by Michael Chevel's group in Montreal showed that almost 3% of children with the diagnosis of cerebral palsy had the diagnosis reversed to a non-CP diagnosis at age 5. So concluding from these two studies, 1 out of 20 or 1 out of 30 children with the diagnosis of cerebral palsy may actually be misdiagnosed. So this finding should put us on the alert, especially when the brain MRI is normal. And by the way, Chevel's study showed that a normal brain MRI at age 2 was associated with a misdiagnosis at age 5 years. So how common is to find a normal MRI in children with cerebral palsy? Well, Chevel's group published in 2013 a population-based study in which they found that brain MRI was either normal or showed non-specific findings in almost 30% of their patients. These were children that were seen between 1999 and 2002. This sounds like a lot, more than expected, and perhaps was due to the fact that they had a small cohort and it was late 90s, early 2000s. And they found that this correlated with the type of cerebral palsy. The dyskinetic and ataxic types had a higher number of normal MRIs than those who had a spastic, either bilateral or unilateral type of CP. The degree of motor impairment did not correlate with these findings. In another study, which was a systematic literature review of population-based studies, reporting on neuroimaging findings in patients with cerebral palsy, published between 1995 to 2012, it was found that 14% of patients had a normal brain MRI. And they found that more patients with normal brain MRI were found in those with a lesser impairment than in those with a more severe motor impairment. I think that at this point we can say that a normal brain MRI does not necessarily exclude the CP diagnosis, but increases the level of suspicion of a possible CP mimic. So what are possible CP mimics that one should consider? Well, Doctors Appleton and Gupta provided us last year with an updated list of most of the CP mimics according to clinical presentation. I'm not going to go over this long list of different metabolic and genetic etiologies. Instead, due to time constraints, let me review briefly those CP mimic conditions that they may present as a spastic diplegia or tetraplegia. So let's look at this list. Adrenoleukodystrophy, adrenomyeloneuropathy, and metachromatic leukodystrophy will present with neurological deterioration. These are neurodegenerative disorders and usually start showing symptoms between 2 to 10 years of age. Metachromatic leukodystrophy usually starts presenting symptoms at a later age, but it's important to recognize that these patients are going to have a developmental regression and they have a normal development before they start the symptoms. In addition, both of these leukodystrophies will have a characteristic white matter abnormality on the MRI. Aicardi-Gutierrez syndrome is a rapidly progressive encephalopathy of infancy that presents as a spastic quadriparesis, global delay, and microcephaly. Neuroimaging shows calcification of the basal ganglia and progressive cerebral atrophy. These patients also present with CSF lymphocytosis. And at the beginning, Aicardi-Gutierrez syndrome may be confused with CP, but it will rapidly become evident that the patient has a progressive neurological disorder. However, some milder cases in which language and cognitive functions are preserved have been reported in the literature, and they could be confused with CP. Arginase deficiency presents with slowing of linear growth at age 1 to 3 years, development of spasticity in the lower extremities, plateauing of cognitive development, loss of developmental milestones, and seizures. These patients start presenting symptoms at the age of 1 to 3 years, and previously they had a normal cognitive development that slows or stops, and the child begins to lose developmental milestones. So making it obvious that the patient doesn't have cerebral palsy. Holocarboxylase synthetase deficiency is a rare early onset and life-threatening multiple carboxylase deficiency that when left untreated is characterized by vomiting, tachypnea, irritability, lethargy, exfoliative dermatitis, and seizures that can worsen to coma and death. And finally, we have HSP, or hereditary spastic paraparesis, which I think it has the highest probability to be confused with CP, specifically spastic diaparesis, and I will dedicate the rest of my talk to this important CP mimic. Identifying HSP not only has diagnostic, prognostic, and genetic counseling implications, but may also have a different response to treatment. Treatments that we normally use for patients with cerebral palsy. So it is very important to keep these diagnoses in mind and be on the look for them. HSP has had many names throughout the history. It was first described in 1880 by a German neurologist called Ernst Adolf Gustav Gottfried von Strumpel. I hope I pronounced that correctly. My German is not good at all. So anyways, Dr. Strumpel described the clinical and pathological findings of two siblings who presented in adult age with a progressive spastic paraparesis. The disorder was named and recognized as a Strumpel disease. 8 years later, a French neurologist, Maurice Delgado, expanded the anatomical and clinical description of this condition. And for this reason, his last name was added to the syndrome. In the 1980s, Anita Harding from the University of London published a series of groundbreaking works describing the autosomal dominant and recessive forms of HSP and how to distinguish them from hereditary ataxias. Since then, they are known as hereditary or familial spastic paraplegia or paraparesis. We do not use the term familial because it is not uncommon to have patients with de novo mutations in who no other members of the family are affected. We think hereditary is a better term because it indicates the genetic origin of the condition. And neurologists, as picky as we are, we like to use the term paresis because plegia means complete paralysis, and that is rarely the case in these patients. So HSP is not one disease, but rather a group of single gene disorders in which the axons of the corticospinal tract either fail to develop or undergo progressive degeneration, resulting in weakness and spasticity in the lower limbs. Genetic mutations in more than 80 loci and more than 60 genes have been identified as the cause of HSP. These genes encode for proteins involved in maintenance and function of the corticospinal tracts. Neuropathological studies have demonstrated a length-dependent dying back axonopathy affecting not only the corticospinal tracts, but also the sensory tracts, affecting small and large diameter nerve fiber axons. So how common is HSP? Well, it is estimated that HSP affects 4 to 10 out of 100,000 people. CP is 30 to 40 times more common than HSP. Thus, it's not surprising many patients with HSP get misdiagnosed as having cerebral palsy. The main clinical feature of all HSPs is a bilateral, mostly symmetrical, slowly progressive spastic paraparesis. This occurs almost in isolation in patients with pure forms of HSP and combined with other neurological symptoms in what we call complicated forms of HSP. This is a little girl who has a pure form of HSP due to pathogenic mutation in the atlastin gene. She has SPG3A, who, by the way, was originally diagnosed as CP, but because normal MRIs, the correct diagnosis was eventually made. HSPs can be classified according to their clinical presentation, by their clinical manifestation into pure, meaning mostly spastic paraparesis, which can be accompanied by symptoms of a spastic bladder and mild sensory deficits in the lower limbs. And in other patients, HSP, as we said, presents with other neurological impairments like ataxia, peripheral neuropathy, seizures, cognitive impairment, etc. And we call it complicated HSP. HSPs can be classified according to their clinical presentation by their clinical manifestation into pure and complicated. Pure meaning mostly spastic paraparesis, which can be accompanied by symptoms of a spastic bladder and mild sensory deficits in the lower limbs. Complicated are those in which the patients are going to present with other neurological impairments like ataxia, peripheral neuropathy, seizures, cognitive impairment, etc. They can also be classified according to the age of onset of symptoms into early and late. And then we have a genetic classification which uses the acronym SPG, which means a spastic gait followed by a number, which is the order in which the genetic loci was discovered. And lastly, we can classify HSPs by their mode of inheritance, which can be any. The early onset HSPs can be subclassified as infantile, starting before 2 years of age, and childhood or adolescent onset. Obviously, the ones that can be misdiagnosed with cerebral palsy are going to be those that have an onset in infancy. So is there a relationship between the clinical presentation with the mode of inheritance? Well, in general, we can say that autosomal dominant inheritance mode is more commonly seen in pure forms. The complicated forms are more frequently found associated with autosomal recessive mode of inheritance. So what can we say about childhood onset HSP? Well, unfortunately, there is a scarcity of reports in the literature about childhood onset HSP. Most of the literature is dominated by the adult presentation forms. These are two reports on early onset HSP. The first one, published in 2010, with a cohort of 72 patients, in which the majority of them did not have genetic confirmation, showed that the most common form of inheritance was the autosomal dominant, affecting 2/3 of their patients. A study from Italy published this year presented a cohort of 47 patients with more than half of them having genetic confirmation. And they showed a similar percentage of patients affected by the autosomal dominant type of HSP. The majority of them had their symptom onset during the late infantile period. We at Texas Scottish Rite Hospital in Dallas established an HSP clinic in 2012. I will be sharing with you some of the lessons we have learned from a database that contains today up to 200 children with confirmed and suspected HSP. Genetic testing has been completed in 162 of these patients, and we have been able to genetically confirm 76 of them. That means 46.9% of these patients. This slide tells you how the genetic diagnosis was made. Notice at the bottom of the slide that 3 patients with SPG4 were diagnosed by chromosomal microarray. 20 were confirmed by targeted gene testing because they were a relative of somebody that we knew had a HSP diagnosis. 34 were diagnosed by HSP panel, and 19 were diagnosed by whole exome sequencing. So almost 3 out of 4 of the genetically confirmed cases were autosomal dominant. 1 out of 5 had autosomal recessive, and almost 1 in 10 had X-linked inheritance form. Notice that 17% of the autosomal dominant HSP forms were due to a de novo mutation. This graph shows the different genetic types of HSP that are represented in our confirmed cases. There are 17 different genetic forms represented on the slide. In white are the X-linked, in blue, the autosomal dominant, and in yellow, the autosomal recessive forms. As it was already mentioned, most of our patients were affected by an autosomal dominant HSP type, being SPG3A and SPG4, the majority of them. In this graph, the yellow color within the columns represents the portion of patients by each genetic type that started with symptoms before age 2 years. Overall, 68.5% of patients had their symptom onset before age 2. And as you can appreciate, the great majority of them had SPG3A and SPG4. These are commonly pure forms and can be easily confused with a spastic dye cerebral palsy. This graph just emphasizes what I just said. The group with symptom onset before age 2 is heavily dominated by the autosomal dominant HSP forms. And these are the patients that could potentially be confused with cerebral palsy. How about family history? Well, almost 30% of patients with autosomal dominant HSP had a negative family history. This is easily explained by the high number of de novo mutations in this group. And almost 2/3 of patients in the autosomal recessive group had a negative family history. How about MRI? 95% of those with symptom onset before 2 years of age had either a brain MRI that was normal or had a non-specific change, like a thin corpus callosum or non-specific high signal white matter changes. So not uncommon to have normal MRIs in this population. So now let's talk about how severe the motor impairment was in these kids. The majority of them, 72%, could walk independently without any aids. 14% required some type of walking assistance, and 13% were wheelchair dependent for their ambulation. Being the autosomal recessive and X-linked forms, the majority in this group of patients. So what happens over time with these kids? Do they get weaker? Who? When? How much? Well, these are unanswered questions at this time. We have seen a good number of autosomal dominant forms, mostly SPG3As and SPG4s, who remain very stable over the years. Here's one of them that is a child with SPG3A at the age of 4 years, and then at the age of 19. You can see her gait pattern and degree of gross motor impairment pretty much has remained unchanged. We treated this patient with oral antispasticity medications, botulinum toxin, orthopedic surgeries, and we don't know if that really contributed to this stability in her gait pattern, but we have not seen regression in this patient. So now let's finish this talk presenting to you a few other patients with HSP of infantile onset and a few comments about the inheritance pattern group they belong to. These cases will also illustrate how similar they look to CP and how easy they can be misdiagnosed. Both of these children have an autosomal dominant HSP form. The one on the left has SPG10. And you can appreciate his gait abnormality is not that severe. He's totally independent for his ambulation and doesn't require any assisting devices. The one on the right has a little bit worse gait pattern, but still is independent. He has SPG31, and he and the other child have both remained very stable over the years so far. So to date, 22 autosomal dominant HSP genes have been identified. Most patients with autosomal dominant HSP present clinically as pure forms. As you already saw in my presentation, the most common genetic autosomal dominant HSP form is SPG4, which represents 40 to 45% of the autosomal dominant HSP group, with a significant number of patients having a spontaneous de novo mutations. The second most common form of autosomal dominant HSP is SPG3A, which represents 10% of all autosomal dominant HSPs. But it is more common in those with early onset, being as frequent as 29% of all autosomal dominant HSP pediatric cases. SPG31 is the third most common autosomal dominant HSP form, affecting 4 to 7% of patients in this group. Let's now talk about autosomal recessive HSP. This is a child who has SPG56, which is an autosomal recessive HSP form. He also presents with spastic diaparesis and is an independent ambulator, tends to walk on his toes, as you can see, and he tends to trip and fall because of that. So he uses some braces for his ambulation. So to this date, 44 genes that cause autosomal recessive HSP have been reported. The majority of patients with autosomal recessive HSP present as complicated clinical forms. Obviously, this type of inheritance is going to be more common in consanguineous populations, as it's being demonstrated in the study where they compare the prevalence of HSP in Norway versus Tunisia. The most common genetic form of the autosomal recessive HSPs is SPG11. So now let's talk about the X-linked forms. This child has SPG1, which is an X-linked HSP form. He has a genesis of the corpus callosum, hydrocephalus, and adducted thumbs. And he presents with a complicated form because he also has intellectual disability. His gait is of a spastic diaparetic type and requires a K-reverse walker for ambulation. X-linked HSP form is the least common of HSP inheritance type, accounting for 1 to 2% of all HSPs. 5 X-linked HSP forms have been described: SPG1, SPG2, SPG16, 22, and 34. The causal genes have been sequenced for 3 of them. Most of the X-linked HSP forms present as clinically complicated, but pure forms have also been reported in all but SPG1. Notice that SPG2 is due to mutation of the PLP1 gene, and this is allelic to Pelizaeus-Merzbacher disease. It can also cause a late onset HSP in women. So I wish it could be as simple as that, but HSP story gets more complicated due to the fact that some genetic forms may present with multiple modes of inheritance, as is shown in this slide. Well, I hope I have convinced you that HSP is the main CP spastic die mimic, and we should be highly suspicious if the patient presents with a spastic para or diaparesis with no obvious reason by history or MRI of the brain and spinal cord. The presence of a positive family history helps, but unfortunately it's absent in many patients. So this does not exclude the diagnosis of HSP.
So let me finish proposing a very simple diagnostic algorithm. All patients with spastic para or diaparesis of early onset should have a brain MRI to assess for structural lesions like the ones I'm mentioning on this part of the slide. If this is normal, then an MRI of the spine should be done next to assess for possible structural lesions like the ones mentioned on the left side of the slide. And if this is normal, then we need to engage into a metabolic and genetic type of testing to rule out some disorders that actually have the potential to be treated. And like is the case of Doppler responsive dystonia, which I didn't mention at all during my talk, but I'd like to present to you this case. This is a kid who came to our hospital because of tall walking, and the tall walking will get worse by the end of the day. And the interesting thing was that her mother had the diagnosis of CP, spastic die. That's her mother here on the video. And she had actually not only been diagnosed with CP, but also had orthopedic surgeries when she was a child. Well, the possibility of having obviously a genetic disorder was raised, and the first one to think about, because of the fluctuating nature of the equinus, was Doppler responsive dystonia or Sagawa syndrome. And so this was confirmed genetically, and both were placed on levodopa carbidopa, and you can see them here walking totally normal. So these are the type of cases that we definitely we cannot miss, okay, because there is a very good treatment for them. So so this is something that we need to think about when we are seeing somebody who has a spastic die. So the other thing is engaging into a metabolic workup with serum amino acids, organic acids, pyruvate and lactate and other tests to rule out for some of the metabolic disorders that we already mentioned, which they are really rare, and they are going to be unlikely in the presence of what we consider a very stable course with a spastic die type of presentation. So that leaves us with the genetic workup, and the question is, what do I do? Do I do WES? Do I do gene panel? What do I do? So we usually start with a chromosomal microarray. As you saw, we diagnosed 3 patients with SPG4 using chromosomal microarray. If that is negative, then we go into either a gene panel or a WES. These days, I think we have decided to do whole exome sequencing rather than the panel, because there is not that much difference in price. And the problem is, if the panel comes back negative, we're going to end up now spending money doing the whole exome sequencing. So why not to do the WES from the beginning, and that will take care of the problem. And obviously targeted gene sequencing is done in relatives, so patients who we already know what the gene mutation is causing the problem. So that is a very simple way, if you want, of how we approach these type of patients. I'm sure there are other things that people can think of, but I think we need to keep it simple and organized in a way that we can actually come to the right diagnosis. I think the main lesson here is don't quit. Be persistent with somebody who doesn't have a history or has a normal MRI to support the diagnosis of CP. We need to be really on the look for this particular type of CP mimics. Now, understand that we and others have a significant number of patients that we think have HSP, but we have not been able to confirm it genetically, which means that we probably still have several genes to discover. So we still don't know
but every day, every month, every year, we keep adding more and more genetic causes for hereditary spastic paraparesis. So in conclusion, we should not be satisfied with CP as a standalone diagnosis. Rather, we should understand it as a syndrome with an underlying etiology that needs to be identified. And the earlier, the better. CP mimics like metabolic and genetic in origin need to be considered, especially when neuroimaging of the brain and spine is negative. Some of these CP mimics may behave as progressive or neurodegenerative type of course, while others like HSP may not. HSP is the most common CP spastic mimic. Early diagnosis is important for clinical, prognostic, therapeutic, and genetic counsel reasons. So I want to thank my team that makes this effort possible. As they say, it takes a village for HSP and CP. So thank you so much for your attention. And as I promised, here is my email. I hope I hear from you, especially if you have experience with HSP, because we need to start putting together all of our knowledge so we can be able to diagnose and treat these patients better. It's been a pleasure. Have a nice day.
Thank you so much, Mauricio. This is very useful. So underlining, stressing even further your messages. Cerebral palsy is a descriptive diagnosis. It is not an etiological diagnosis. So you must have a cause. We can't always have a cause, but then we need to keep on thinking. The other thing is you also illustrated a number of different cases, and we know that research is still underway. And so some of the cases of HSP that could not have a precise diagnosis a few years ago can now or can in the future. So go back to your mystery cases and keep the box open. Clinically, in some cases, you can distinguish it. I think I published a case and I entitled this Spinal Palsy, expanding. It's not just those genetic causes, but as Mauricio illustrated, also tumors or malformations, that you can have developmental motor problems that are spinal with some spasticity. So I used to think that if you ask children to do this and it improves their gait, it may be a good clinical marker as, no. Children with bilateral CP would improve their gait in many, and children with what I call spinal palsy, it would deteriorate their gait. So, well, take it for what it's worth. I think I published it in Brain and Development back in 2004. Mauricio, happy Thanksgiving. Each one of us, happy EACD. Let's make the most of this meeting. I just love it. Thank you very much.